The following program is rated GE. It is suitable for general family viewing.
Ladies and gentlemen, welcome to Body Garage, the Art of Wellbeing. This is another Thursday and we have very interesting conversation tonight because these guests have appeared on this show before, but today they come with another hot plate of conversation, right? Yes. Karibuni sana.
Asante.
Thank you.
Before we go into the discussion, because I know once the discussion starts, it's going to be a hot one. Please introduce yourselves to the audiences.
Thank you very much, Daktari. My name is Kenneth Ogendo. I'm a public health specialist and consultant, and I do that by day, and I'm a fitness, health, and lifestyle coach by night. But more importantly, for today's conversation, I come in as the chairman of the Kenya Environmental Health and Practitioners and Public Health Practitioners Union, and we are here to speak issues public health and the status of health in the country. Primary health care.
Primary health care, yes.
Thank you, Dr. I am grateful to be in the show. To the viewers, my name is Brown Ashira. I'm the Secretary General for the Public Health, Kenya Environmental Health and Public Health Practitioners Union, an umbrella body bringing together all practicing and trained public health officers and technicians in this country. I'm also a PHO by training and by practice. Thank you. I'm happy to be in the show.
Karibuni sana.
Asante.
Now, let's get into it. When you look at this Kenyan health system, primary categorized broadly into three, right? The primary, secondary, tertiary, but again they are levels, right? So let's talk about those three categories and the levels a bit just briefly.
So the Kenya healthcare system is into several levels, like you've said. We have level 1, which is the community health services level. We have level 2, where we have the dispensaries and health centers. We have level 3, where you find the sub-county hospitals and county hospitals, where you have level 4, and those are in level 4, and level 5, where you have the referral hospitals, and level 6, where you have the referral and tertiary hospitals, where now you can have the Moi Teaching Referral Hospital, Kenyatta National Hospital. So it's basically linking the health continuum from the lowest level to the highest level, from level 1 all the way to level 6, primary, secondary, and tertiary. And our interests as the public health officers and specialists is in the primary healthcare level, which has the community level and the dispensaries and health center levels, where those two need to be linked to one another for purposes of creating demand and supply within the healthcare divide.
Wow. Brown, anything to say?
In the interest of the recently ascended to acts by His Excellency the President, we are talking about the Cuban model, that is the hub and the spoke, whereby now, just to add to what the chairman is saying, the hub represents the level 4s, 3, 4, and above. And then the spoke now is level 2, 3, and 1, where the chairman now has spoken clearly, where in the level 1, at the primary healthcare level, at the community, is where now you get the public health officers and technicians, you get the community health workers, the community health promoters, who are people doing preventive to preventive healthcare, and also doing a bit of curative and a bit of curative. So it's purely done at level 1. So that's primary level care level 1. Yes.
So when you look at the Kenyan history in terms of our healthcare,
yes,
where have we been dwelling mostly?
It's unfortunate, and I think I want to thank His Excellency the President. This country, the trajectory has taken a good trajectory, because when the Kenya Kwanza government came in place, they mentioned that they're going to dwell much on preventive healthcare as opposed to traditional curative healthcare. We have been investing much more in curative as opposed to preventive, and Research has shown that $1 a day spent on prevention results to almost $8 that are saved. So I think that's what we have been lacking. And if you look at the disease burden, over 90%, actually 80% of the disease that we are treating in this country, in the sub-Saharan Africa, in the tropical sub-Saharan Africa, they are purely preventable diseases. We talk about diseases like cholera, diarrhea, hypertension. Those are purely preventable diseases which can be prevented, especially when we invest much more in preventive healthcare. And maybe to add, you know very well that the Abuja Declaration talks about 15% of the budget going to the healthcare. But if you can give an example in this country, even going by the last budget, you realized quite a huge chunk of the resources that were allocated to the Ministry of Health, a huge chunk went to the curative as opposed to the preventive. And it goes without saying that even education got much more money. It's laughable. Okay, education is as important as health, but one has to be healthy for you to be in class. So it goes without saying that health should be the backbone of what is supposed to be done. So it's a challenge, but I think we are moving in the right direction.
Now, so preventive and curative health and all those and the levels. We have what has been recently introduced officially, that is, but something that has been in discussion for quite some time, about the community health workers. Okay, at what level are they coming in?
So thank you very much for that question. And just to add on to what my colleague has mentioned, the government has finally woken up and smelt the coffee. It is high time we go back to the cradle of humankind in matters of public health. You know, public health began way back 150 years ago in sanitation. And even when you look at the good word, the Bible, public health began all the way in the Mosaic laws, where the Bible has been trying to sanitize our hearts. And we, as sanitation inspectors back in the day, we have grew into the discipline of public health. And we have realized that the only way to secure the health of our people is to prevent diseases. So the paradigm shift from curative ideologies to preventive is a huge milestone in this country. And on the 20th of October this year, we were able to celebrate the recognition of community health workers. So speaking to community health workers, we have them globally as lay people who are trained and given basic skills to go and talk to their households, families, and teach the family members how to prevent diseases, how to wash their hands with soap and water, to refer women with danger signs to the hospital, to refer children for vaccination, to create demand for health services. So community health workers have come in to take care of the shortages of the human resources for health you have in sub-Saharan Africa. So this is an idea whose time has come, Chebsi, that when you put all the forces of the world together, you cannot fight. An idea whose time has come. It is time to embrace community health workers. In this case, in this country, community health promoters, for us to move the needle and reduce the morbidities and the mortalities of the diseases that our people are dying of. We have people dying of preventable deaths in this country. And I think their role is basically to link the community health, or rather the communities, to the formal health facilities. And that is their leverage.
If I can cut you short, like, you know,
Yes.
we are using big terms, primary health care, level 1, but let's dwell on primary health. What exactly is it? You know, to the people, to the public, this is a technical term, this is jargon. For us to understand where the community health worker, we need to understand at that level where they come. So primary health.
So primary health care is defined as the basic essential health package that can be given to the people in the communities through technologies or through interventions that have been proven to be scientifically sound, to be affordable, to be available and accessible, with the aim of making sure that these communities have what we call self-determination and can be independent. And what I mean by that is the goal of the primary healthcare framework in this country is to empower the communities and the facilities to ensure that we have got promotive and rehabilitative services as well as curative at one-stop shop. And that's why we have the hub and spoke you talked about. Every community unit in this country and every household will be mapped by the government, and they'll all be linked to a community health unit, which is also linked to a health facility, which will also have a multidisciplinary team of doctors, nurses, public health officers, and all the other people that are operating at that level, so that when you go to the hospital, you have all those people as the one-stop shop. And that's what we call the primary healthcare network. And we are collapsing the silos that have existed over time. To break it down for Mama Mboga there at home, when you go to a health facility, for many years you've been told ile ni laini ya maternal clinic, vaccinations are there, TB clinic is there. But now when you bring in all these disciplines together, a woman or a child will be observed by multiple persons at the health facility, and they will not be able to leave anything to chance. So we shall not lose our kids or our mothers and fathers to needless deaths because you have been checked by a healthcare worker who is not specialized in a particular area. But for that to happen, you need to have screened the community and filtered which people really need to go to a health facility. You know, Chepsi, you're a doctor, and you'll bear with me witness that a doctor or a health care worker in a facility has the propensity or the capacity to clerk maybe 8 patients in a day if you're supposed, if you want to give good quality service. But now when you open the door and you find the line is from here to Timbuktu, you'll declare all of them have malaria. You'll do what you call a clinical diagnosis. And you might not even send them to the lab because you have no time. There are so many. And this is the power of community health in primary health care, where the community health worker will clerk at the household and treat all the minor illnesses in something which in some ideology we call integrated community case management. Diarrhea, malaria, malnutrition, all those can be sorted at the household level, and they refer the complex cases so that you who has done masters and higher diplomas can handle the complex cases at the health facility with fewer patients. So reducing the workload, that is one of the biggest ways community health workers are helping the health system. And we are glad that finally our government and Kenyans are seeing the light. And basically that's what we mean Afya Mashinani, primary health care at the household level, linked to the health facility, where the community health promoters and the public health officers are working with the facility in charges to make sure that there's a continuum of care, that we are not losing anyone through the cracks.
All right. Thank you. Thank you. Now, the next question will be about what you've mentioned about community health workers taking care of the minor ailments. We are going to take a break. When we are back, Brown will pick it up from that conversation. Yeah. So let's take a break, and when we are back, we continue the conversation where we have left. All right, welcome back. You are watching Body Garage, the Art of Wellbeing, and we are talking about primary health care. And Chairman, as he calls you, you raised an important point which you wanted to contribute. Then we continue the conversation. Yeah.
Let me tell you, Daktari, you know, I was privileged to be among the invited dignitaries at Kericho. I went there not as Brown Ashira, but I went as a Secretary General for Kenya Environmental Health and Public Health Practitioner, as you know, are very critical and a key stakeholder in prevention in this country. You know, we are a very unique cadre. We do prevention, and our work is to decongest. I keep saying our main goal as public health officers and technicians in this country is to decongest hospitals. And when you're talking about decongesting hospitals, we mean we do not want people to suffer. We want people, in the event, the kind of the monies they have, they use it for development and other things, as opposed to suffering from diseases which can be prevented or rather which can be avoided. Going back to what the chairman has said, community health promoters is not a new idea. Actually, that idea has existed even before. We used to call them community health volunteers initially. We used to work with them. We used to supervise them. When CHS was coming in place, and I'm happy Dr. Ogendo here, you know, is a specialist doctor right now. When he was there in the year 2007 under the whims of Dr. Njikal and Professor Miriam Were and all those guys, the likes of Kina Makbor and the rest, they gave birth to CHS. And they did not just give birth to CHS, but CHS came from alma mater in 1978. What they did is they domesticated it, and they gave it the wheels to move. You know, by then, community health strategy. That by CHS I mean community health strategy. So it began from there. We gave birth to, and thanks to Dr. Kefombacho, thanks to Dr. Muitari, and all those key guys whom we keep failing to mention and appreciating and recognizing them. When I was at Kericho, when the president was flagging off this project, as healthcare workers in this country, we made a declaration that we want this PHC to work, that is primary health care to work, and universal health care to work. And it couldn't work without what now chairman is talking about, the healthcare workforce, because healthcare workforce is a pillar. And this is where now we're coming into the community health promoter. And a community health promoter is not a doctor. You know, we must demystify that myth that, you know, when we must be careful, you know, when we're talking to the community, those are people who are selected from under Section 9. If you go through the Primary Health Act, Section 9, it spells out the criteria on the appointment of this community health promoter. And
that's what I wanted to ask as
yes.
we continue that conversation.
Yes.
What is the scope of practice? What is the training level for the community health workers? Because you said that they will be able to deal with some of the minor elements that might not need to go to the hospital. But the doctors are looking at it in the other perspective, that yes, you might have a situation where somebody has been attended to by the community health promoter, and they have been told they're okay, and maybe it's a serious case, and they stay and they go to hospital when it's already late. So what is the training levels? What is the scope? When are we going to know this needs to be escalated as soon as possible?
Before Chairman comes in, I wanted to highlight who is a community health promoter. And I wanted to tell you that this is somebody who's appointed at the community level. Somebody who's appointed, actually not even appointed, selected. The Section 9 of the PHC Act stipulates the modus operandi, how they are going to be selected. And somebody who's selected doesn't mean it's somebody who's qualified. You know, we must get it right. This is just a volunteer who has been upgraded to a promoter. But the law also provides us a case whereby the county government shall put in place mechanism on how to train these people on short-term courses to ensure that they work. Actually, the essence of a CHP is to work with this MDT, what the chair said, the multidisciplinary team. For example, when you identify a case on house to house, because they are kitted, they are given kits. When you go to a household, for instance, for example, in Kilimani, and you realize that household has an issue. Together, if there's an issue about drainage, for example, you refer to a PHO, the area or the ward public health officer in that particular locality. If it's a case of TB, for instance, there's a way, that's why the chair was saying, they are linked to a facility. So they do not, they actually are supposed to be trained, but they do not have specific requisite training that is supposed to make sure that we can call them doctors. There are people who have been empowered, and that's why we are saying that they're supposed to be working with the professionals to ensure that they are guided, because if they are also not left unguided, it also becomes dangerous. You know, we cannot play politics to the people's lives. We must be able to pair, and that's why the law is clear. This person is going to be paired with a PHO, is going to be paired with a nurse, is going to be paired with a nutritionist, is going to be paired with a clinical officer and a doctor, so that to ensure that in the event there's an issue about this, the relevant professional person takes precedence. Yeah, so that's what the scope CHP is supposed to be. And we supervise them, like Chair said. We have been working. The reason why we supervise them is that because if there's an issue of that nature, they report to us, we supervise and maybe direct them on what is supposed to be done.
All right.
Yes.
Okay. Yeah, maybe I can quickly chip into what he has mentioned. And first of all, I'm happy that you have been able to salute our forefathers and mothers. We have Professor Miriam Mwere, who has been the Community Health Services Goodwill Ambassador, medical doctor by profession, but public health at heart, a health systems thinker, Professor Dan Kaseje, and all the others that he has mentioned, Dr. Kefo Mbacho, Dr. Mwitari. We have had great people who we really appreciate. So I wanted to talk about this scope of practice and say that I've had the rare privilege of supporting the documentation of the community health workers' curriculum in this country and supporting the documentation of the training modules. And the government has already supported the development of 13 basic modules, 6 basic modules and 7 technical modules. And all these give them the basic skills to handle illnesses at the household level. And they are trained in a way that they know that this is an issue I can handle. If they see fever in a child, they know they can take temperature with a thermometer and either administer paracetamol or refer to the health facility. They are trained on family planning. They are trained on nutrition. They are trained on water and sanitation. They have all those packages there. Now, what the county governments need to do, like he's saying, is to make sure that they train them and supervise them, because training is one thing and supervision is another thing. And the beauty with the community health workers is they are very amiable persons and they are a resource to all of us. They have a kit that they were given, and this kit has got particular commodities, including blood pressure machines. Those kits have glucometers, and those are the two that have been talked about mostly. And I can mention that they also have a non-communicable diseases module. They are trained to take sugar and BP. And when they see the readings, based now on the tools they have, because they have now been kitted with mobile phones, smartphones, they can put in those readings and interpret and refer. And I've seen this working. You might think they are very lay people. You might think they are not intellectually capable, but I tell you, they are sharp people, because the government wants people who can read and write, and they can refer cases to the health facility. So that's something they can do under supervision of the public health officers and the community health officers who work down there at the grassroots levels.
So what are we expecting to see? Like the Mwananchi is watching this show. What should people expect in terms of their health now that we have the community health promoters? What are the tangible things that we expect to see at the ground?
One thing I expect, like you have mentioned, they will be visiting all the households in this country. I visited some counties some weeks ago, and I saw they are already registering people on the electronic community health information system, which allows them to take data and use data for decision making. It allows them to count how many households have toilets, how many households are referring their children for vaccination, how many households have got women of reproductive age who need family planning services. It allows them to understand how many children are going through malnutrition. Right now, you know, quite a number of Kenyans are going through undernutrition as you're speaking. So the technology they are leveraging on is going to help the community health workers serve the Kenyans. And that's why we are happy that the 100,000 community health workers supervised by public health officers and other community health officers out there are going to help visit every household, screen them for all these diseases, including disability. You know, disability is usually marginalized. So they are going to count and take stock how many people are having disabilities within their households, how many have chronic diseases, how many have mental health issues. So they are a big cog in the wheel. They are a big spoke to the hub, and community health workers need now to be given the trust by Kenyans to serve them. And they are able. Now, if you have diabetes and you're a lay person, you can actually inject yourself insulin. And which school have you gone to? Sembuse, this community health worker who is trained by healthcare workers for a good number of days and supervised. So they are about to do a better job. You know, when you talk of task shifting and task sharing, community health workers are ahead of the curve. And now with artificial intelligence, soon we shall be having wearables where community health workers atakuvalisha tu saa and they get all your vitals and ECG. The future is bright.
So Brown, what are we expecting to see in terms of the impact of community health workers to their input to the general health system? Those who are largely at curative level, let's say the doctors and the clinical team, will feel that there is a challenge with the scope of practice of the CHPs. They might at the end contribute to more people becoming sick because you're taking too long to come to the hospital. Is that the case? So we hold the thought and then we take a break and when we are back, you just pick the conversation as that. All right, welcome back. You are watching Body Garage, the Art of Wellbeing. We are talking about primary health care. Yes.
Yeah, I'll say this. Thank you for that question. I'll say we have a lot of work to do as healthcare workers in this country. One, when the president came in force, he said that's going to employ 20,000 healthcare workers. And I'll keep referring to Kericho Declaration because that's where the eye meets the road. And we said that we want healthcare workers to be employed. We cannot entrust the Kenyan lives with community health promoters alone. We need, the same way we employed 100,000 community health promoters and going, we must ensure that we have adequate public health officers. The WHO ratios, we must be able to match the gaps. There are gaps in clinical care, there are gaps in public health, there are gaps in doctors' care, and we must make sure that we address the gaps. And coming to your question, we have a lot of work. We must sensitize our people. We need to know that the work of a community health promoter, where I stand, is not to treat diseases. Their work is to ensure that we identify. Actually, the law says, you know, I'm appraised with the law because in Section 9 it talks about treating minor ailments, like first aid issues. They deal with the first aid issues. But in the event of an emergency, they are linked. These units, actually, they are linked to a health facility. They are supposed to refer. They make those referrals, those linked facilities, so that immediate action is taken care of. I want to give an example. For example, I'm having cancer. And I'm a TB, for instance, and there are people who resist, they don't take drugs for TB, for example. And then maybe a CHP comes in my house that a community promoter and realizes that maybe Brown Ashira is not taking his drugs, I'm not taking the work of that CHP is to ensure that I report the case either to a PHO. The PHO will take an action, for example, involve other relevant authorities to ensure that the life of this person is very important. He makes sure that he goes back and takes drugs, for example. Sort of an enforcement and sort of just to enhance healthcare service delivery, the way my chairman has said. So the work of a CHP particularly is to make sure that we work, we correlate, we integrate in our service delivery, that we have them identifying those things, the early signs. Disease surveillance, for example, if there's an outbreak, that issue can be reported through community promoter, the relevant persons that are able, that issue can be addressed to the latter. Yes.
Ken, what is the cost benefit per CHP? you're employing 100,000 to start with, right? Those are people who are going to be under salary, right? Or some kind of stipend. Are we increasing the healthcare costs, or we are creating a benefit? Are we going to make, by what I still stand by what I mentioned, that you might end up having people staying at home more comfortably knowing I was seen by a doctor. And then by the time you arrive at the hospital, it's too late. So we might end up having more sick people and overall increasing the overall healthcare expenditure per person.
So you've asked two questions in one, but I will just start from the foundations and say that community health promoters are a subset of the public health workforce. Globally, they contribute to the public health agenda. And public health, as we began back in the days, like I mentioned, is mostly domiciled in the application of the law, where we have CAP 242 and CAP 254, and we also have the Meat Control Act and many others. But as much as we are using the law to change behavior, we also want to appeal to the heart where the emotions sit, so that we can convince you to change behavior without necessarily dangling the carrot to you, because public health has got those two dimensions. Now, community health is about appealing. It's actually a modality for social transformation, helping communities know that they need to build their toilets. They need to embrace family planning so that they can fight poverty. It's about a community health worker coming to your house and telling you, if you have 10 children, you need to embrace vasectomy. And they will not put a gun on your head, but they will convince you every day that if you don't take your TB drugs, then you are going to die. So they have to talk to you slowly. But on the other hand, the Public Health Act, we shall jail you if you don't take your drugs. So we combine these elements to change behavior. So there's no way that people will stay at home because this is a doctor. They are not really doctors. However, wako mashinani wanaitwa madaktari, which is good for their ego reward. It is a reward system. Ukimwita daktari anafurahi sana. Na ni ukweli ni madaktari mashinani. They are not the doctors, in the hospitals or ivory towers where they are so far from the people. They are on the ground. And the way they are trained, remember, capacity building is very important. The way they are taught, that's what they do. And I've been with them for the last 15 years. I've seen the way you teach them, they deliver as taught and make sure there's supervision. They are the ones who fish out children with disability at home. The ones who hide them, they bring them out. They are the ones who find women who are bleeding with danger signs at home, not knowing that they're actually supposed to go and be checked in the hospital. The community health workers are saving lives. There is empirical evidence. There's a lot of studies have been done that are proving that community health workers are reducing morbidities and mortalities on NCDs, on maternal health. So many women do not know when contractions are happening within their bodies, they need to be rushing to the hospital. But because of the teachings on maternal health, they are able to advise the women who are pregnant to run to the health facility on time, saving lives. So there is no fear for that because you already have a lot of data to support that. So talking about financing, that was the other question. We have 100,000 community health workers, and it is not me, as you said, it is the government of Kenya that wants to work with them, and we are all supporting the agenda. And the president said, and if you look at the maths, they have put away or aside 3 billion Kenya shillings. And there is a conditional grant upon the counties to raise a similar amount, another 3 billion, to make it 6 billion. And 6 billion is what we need to sustain the 100,000 community health workers on a stipend of 5,000 shillings, with the county governments giving 5,000 and the national government giving 2,500 from the national government and 2,500 from the county government. So it's a dollar for a dollar, a shilling for a shilling. If the county governments can match up to what the president has given them, then we shall walk smiling in the community because they will be more motivated. Remember, as we talk to them, their main motivation is usually not money. That's what research is actually showing us. That's why they've been called volunteers for a long time. Their main motivation is to have the social reciprocity at the lowest levels, to take care of your neighbor and see smiles. So this money is going to take them to the next level and get airtime and put food on the table. So what is interesting, Chepsi, is this. We spend 500 billion on our healthcare in this country.
That's the overall.
The money we spend as a country, 500 billion. We also spend 150 billion on out of pocket. So you can see the money we are spending treating diseases that are treatable or preventable for that case. We are sending so many people to India and other countries. Through now the defunct NHIF, now we have a new one. So we have been putting a lot of money, we have been reactive. So we are proposing to the government to continue investing in preventive mechanisms. You know, for every dollar you invest in community health, it has been proved through empirical studies, you save $9.8. The return on investment is brilliant. In the US, for every $1 invested in community health, community-based mechanisms is $1. $1 has a return of 5.6. And in the next 10 years, it is estimated to even go higher. So you find we are not the only ones who have been marginalizing public health. We are not the only ones who have been marginalizing community health workers. It is a global phenomenon, and now we have a global call to see how we can pay community health workers sustainably. And this is what I'm studying, and we are supporting as a union to see how can they be taken care of to make sure they offer services at the last mile sustainably.
Do you have anything to add?
I'll say this for a fact. 5,000 to me is not money. We are not serious. If I give you 5,000 in this, they are calling in quote Sakayo economy, what would you do with that money, Doctor? We must ensure that we revamp our healthcare promoters. These guys are doing a commendable job. Imagine I give you 5,000, you stay, for example, from here to another place. That money is not enough. And number two, who takes care of their security? If they are going around those households, assuming they are mugged and what have you, and even those kids, you know, we are in a funny society. When somebody is hungry, when I walk around the bag, for example, and I'm hungry, and you pass through somebody can even think that I'm holding a laptop or I'm holding a gadget that I can take out and then maybe sell and earn a living. So we need to ensure that our people, the community health promoters, have been thoroughly kitted. The other time I was in TV, we are with TV 47 with Duranira, the presidential advisor on Afia matters. Even in Nairobi, you know I work in Nairobi. There are even other community health promoters who do not have the kits. And I spoke in the TV that day, and I'm happy when we spoke there, they were kitted the same day that I spoke. So we need to go beyond the money. We make sure that we provide security for these people. We do what is the training that he has said. We must, health is growing, it's dynamic right now. It's growing day by day. The world is evolving. So we must also make sure that we keep revising them, we keep educating them, we keep training them on the new modalities and the new dynamics in disease prevention, in disease surveillance, so that they're also at par with what we are talking, what we are saying. So they are important people, and let's ensure that we keep more money in community health strategy and also in public health. Thank you.
We are out of time. Just briefly, Ken, how will be assume that household is a patient, how is the flow going to be? They have been seen by the CHP. How will the flow of care be?
I want to mention that all decisions affecting the health of a community, the health of this country, happen at the household level. And that's why this idea of embracing community health strategy in totality by empowering the community health promoters is an idea whose time has come. If it does not happen in the community, then it never happens. The decision to put on a mosquito net happens in the household. The decision to make babies happens in the household. And even the decision to wear a condom to prevent diseases happens in the household. And hence, we need to empower decision making at the household level. And that decision making needs someone to come in and mentor that household and put them on the journey of the continuum of care. That's what we want this country to do. So when a community health worker comes to your house, I'm assuming they will come with a mobile phone, the smartphones that they were given, with the electronic community health information system, ECHIS. They take all your details, your children ages, and all the issues around your household, sanitation, and also looking at your age. Do you have sugar? Do you have fever? And the mobile phone, or rather the app, has got algorithms and inbuilt decision-making algorithms or features that help the community health workers make a decision on a real-time basis. Remember, the same phone has got some dashboards. They can see how many women they have visited, and they can see the last time they were in your household. So whenever you make a decision there, they look at you. If they can treat you there, the main illnesses, then they'll give you paracetamol. They'll give you AL. They'll give you zinc and ORS if your child has diarrhea. If not, then they refer you. If you have blood in your diarrhea, they are going to refer you to the nearest health facility. And hence, a message should be sent there. And the last time I was in those conversations, I'm hoping that they have put in the two-way mechanism, the two-way referral mechanism. So the workflow is from the household all the way to the health facility, and the community health supervisor, the public health officer, also gets messages or validation messages showing how they're doing their disease surveillance and can tell which community health worker is going to which household. And they can also look for the people who have defaulted. When they get the list of defaulters from the health facility, they can follow them back to the health facility. So the referral loop is closed by utilizing the community health information system that now is electronic. So the future for this country is bright if we keep the technology and innovation high and empower them and supervise them. And the public health officers, we are there to support them. It's our baby. We give birth to it. And we are encouraging doctors, nurses, and everybody else to come together. We work forward with the health systems thinking, mentality, and approach.
All right. Thank you. Thank you so much. I think because of time, we have to stop there. The conversation has been good and enlightening. Maybe we can pick up on it another time.
Thank you.
Yes. Thank you so much, gentlemen, Ken and Brown. All right. We have come to the close of our show, and I trust that you've become enlightened about what the community health promoters are all about and what primary health care is. And as you've heard, there's a promise that health is going to be better in Kenya because of their existence. I've been your host, Dr. Shepsi, and this has been Body Garage, the art of well-being. We will see you next Thursday.